all show you some poor data on factor 11 inhibition. I have loads of disclosures, which means we have money to do research. So disclosure used to be bad in the past, is very good now. Well, you all know the development of vitamin K antagonists, then heparin. Then in 2000, we came up with fondaparinux, and then we came with the DOACs, 5 of them. One is factor 2 inhibitor, dabigatran, 4 factor 10 inhibitors. They are a massive success, but there are some gaps, particularly bleeding. That's why we are developing the factor 11. We started in 2020, actually a little bit earlier than that. 2015, we started working with factor 11 inhibition. And the idea is you can live with a factor 11 deficiency like hemophilia C. People with low levels of factor 11 don't die by myocardial infarction, so probably it works in the arterial side. We developed the factor 10. It works for atrial fibrillation, for VTE management, treatment, and maybe a little bit of prophylaxis, but still we have bleeding, particularly on strokes and on the CAD and PAD realm with GI bleeds. So maybe these drugs would work. That's why we developed factor 11. And we have now probably 22 different factor 11 inhibitors. We have small oral molecules, IV synthetic drugs, monoclonal antibodies, and I'll show you the data on monoclonal, and we have also the blocking RNA antisense oligonucleotide technology. So be prepared to see probably 22 new anticoagulants in the factor 11 inhibition. And they feel here, you see, this is the old coagulation cascade. On the left side, red, you see the names of the factor 11 we are developing. The three most important are milvexian, asundexian, and abelacimab. That will show you the data and what's going wrong with them. So globally, there are 2 big programs. One led by the junction of BMS with Janssen, it's called Librexia, and the drug's called milvexian. So we're working in stroke, atrial fibrillation, and ACS. This program is fully ongoing, no interruptions. The other big program is with asundexian, and we were developing it for atrial fibrillation and stroke. And the tragedy happened in the atrial fibrillation trial. It was interrupted by lack of efficacy. So this is the major drawback, Professor Emad. So when we look for milvexian, which is the BMS factor 11 inhibitor, it worked beautifully for VTE prevention after major orthopedic surgery. We published this data in the New England. The phase 2 for atrial fibrillation comparing asundexian to apixaban, which is extremely safe, worked, showed that it bled less, so people were entitled to do a trial with 20,000 patients comparing to apixaban asundexian. And this is the tragedy, this is the big drawback of the factor 11 inhibition. So we randomized 18,000 patients that some of them were already on anticoagulants, apixaban, rivaroxaban, dabigatran, edoxaban, or warfarin, to either receive apixaban or asundexian, looking for major bleeds. But we needed to be non-inferior in preventing these patients for stroke. And the trial, unfortunately, was interrupted last November because of lack of efficacy. It didn't work. So this compound at this dose, 50 milligrams, did not prevent strokes. So this is the big tragedy, the big drawback of factor 11, 3.79 more ischemic strokes on patients with atrial fibrillation. So imagine, we transitioned these patients from warfarin or from other drugs to the trial, and almost 100 of them had a stroke. We needed to interrupt the trial in the middle of the data collection in 500 hospitals everywhere in the world. So it's a major drawback. It's a major setback because it didn't bleed. And as expected, 50 milligrams of factor 11 didn't bleed, but the trial was interrupted due to lack of efficacy, hindering the whole factor 11 biodevelopment program. So the other one who is doing okay, and we're expecting good results, is abelacimab. Abelacimab is from a small company in the United States, a single shot. It lasts 30 days, and it's a monoclonal antibody, anti-factor 11. It worked beautifully in VTE prevention for orthopedic surgery. Imagine, a single shot to prevent VTE after major orthopedic surgery. If it comes to the market, it's going to be nice for us. They are developing a full program to treat cancer-associated thrombosis. It's called Magnolia and Aster trials. We're in the middle of it. We don't have data. And recently, the company showed the phase 2 study in atrial fibrillation comparing to rivaroxaban, and it did not bleed. Actually, as a matter of fact, 67% less major bleeding, clinically relevant major bleeds, 74% less major bleeds, and 93% less GI bleeds. We don't have efficacy data. It worked in 1,200 patients, but we don't have the final trial. So factor 11 is extremely safe, but we need to focus on the dose to find the correct dose for efficacy. So in summary, pretty much on my 8 minutes, factor 10 and factor 2 inhibitors are totally validated for stroke prevention, for venous thromboembolism treatment, either pulmonary embolism or in DVT. It works for peripheral artery disease and cancer-associated thrombosis, but we have bleeding as a major issue, gastrointestinal bleeds in the arterial side, and intracerebral bleeds on the stroke side. That's why we are developing factor 11, but we had a major issue with the trial for atrial fibrillation with Bayer. So still we have a massive phase 3 program. None of them are available yet. We're looking for new indication, but we suffered a major setback in the factor 11 inhibition with the Oceanic AF that I just showed you the data. 3.79 more strokes, very unfortunate. And I finished my presentation. If you want to have free education on anticoagulation, this is my Instagram. It's called Cardiovascular Talks. Every single trial, I put some Instagram there discussing the trial, discussing new data. And I'm doing it I was doing it only in Portuguese. Now I'm doing in Chinese and in English. So thank you, Professor Eman, for the nice invitation to be here.